Good afternoon, everybody. I'd really like to take this opportunity to thank Dr. Ashish Singh, a very good friend and a fantastic orthopedic surgeon, joint replacement surgeon, for organizing this fabulous conference and giving me this opportunity to present my talk on reverse geometry shoulder arthroplasty on cuff tear arthropathy. So, little bit of a historical perspective. So, reverse shoulder arthroplasty is not new, and initially it was designed by Neer in 1970s, and which was named as Mark 1, 2, 3, but it had limited success. It was good at relieving pain, but long-term outcomes weren't that great. So, in the 1980s, there was a change in thought process. Modularity of components came into place, and it was mainly the work of Paul Grimaud in 1985, and along with it came the delta implants, which really changed the scenario. And then it was some groundbreaking work from Mac Frankel and Jill Walsh, who popularized this reverse shoulder arthroplasty with their wedge-shaped inserts. So now, what are the indications of a reverse shoulder arthroplasty? Mainly, you can do it for osteoarthritis. The main indication I would say is still massive irreparable cuff tear arthropathy. Obviously, it can be done in irreconstructible 4-part proximal humerus fractures and in AVN cases as well. So, why is it reverse? Because in conventional, you put the ball where it should be on the humerus and the socket where it should be on the glenoid, but in reverse, you reverse it. Why we reverse it is again talk for another day, but the thing is that we reverse the component so as to medialize the center of rotation of the joint, which lies at the center of the ball. So if you put the ball on the socket, you medialize it. That way, you increase the moment arm of the deltoid, and the deltoid can then work in the absence of the rotator cuff. So the function of the rotator cuff is to depress the humeral head so that the deltoid can work on it. So when you medialize the center of rotation, the deltoid can function without the help of the rotator cuff. Now, this is actually what I've just spoken about. So, there's an enhanced mechanical advantage of the deltoid, which compensates for the deficient rotator cuff, and deltoid becomes the primary elevator of the shoulder joint without needing an initiator, that is the supraspinatus. So what happens in the rotator cuff tear arthropathy? There are 3 critical features. So you have a rotator cuff insufficiency, so there is a hole on the top. The depressor is absent, so you have a superior escape of the humeral head, and further it leads to degenerative changes in the glenohumeral joint, and at the end stage you can have what we call as acetabularization of the acromion, and if we leave it, then there could be an acromion fracture as well. So, deltoid function, I don't think I need to go into details about it. So, what are the prosthetic components? You have a glenoid base plate, which you can either screw into the glenoid, or you have a rod which press fits into the glenoid. Then you have a glenosphere, that is the ball. And then you have the humeral component, which can be an inlay type or an onlay type. The benefit of the inlay type is that it seats very well into the humerus, but then there is no lateralization of the humerus. So there is a concept of medialization of the center of rotation head, but if you want a better abduction and less impingement on the scapula, you need to have slightly lateralized humerus, which you can get with a onlay component. Now, what are the workups? Standard workup, you need to have a good AP and lateral view. On the lateral view, you can judge little bit of the version. You can have ultrasound or an MRI to confirm a cuff tear, though it is not mandatory. What I feel is really needed is a CT scan to judge the version of the glenoid and the wear of the glenoid. So what are the anatomic variables in the pre-op planning? You need to put your glenoid in a rough guide is about 5 degrees of retroversion, but it can be from 2 degrees anteversion to 7 degrees of retroversion. Humeral head, anywhere between 20 to 40 degrees of retroversion, and an axial CT scan is an important tool. This is all the equipments you need for your trial and things which you do for other joints as well. So let's look at this case. So this is a lady who is 66 years old, severe bilateral shoulder pain for last 3-4 years, consulted a few doctors. She had rest pain, night pain, unable to sleep. Now, unable to perform household work due to pain. She was right hand dominant. And she had a past history of Pott's spine with paraplegia, treated non-surgically on AKT. Now, this is the most important part of my planning, where I get the axial CT scans, and this CT scan actually shows me what the glenoid looks like and what the version is. So here there's not much wear of the glenoid and not much retroversion. Why do we need this? Because if you have a retroversion up to 15 degrees, you can correct it by centric reaming. If you have something more than that, then you need either a wedge component or you need some augments. This is my poor surgeon setup, where I don't have a shoulder table. So I pull the patient to the side of the table, because you need the hand absolutely free to have full extension at the back, and you need to be able to fully externally rotate it. So the approach, I do all my shoulder surgeries either for fracture or for the shoulder arthroplasty via deltopectoral approach, which is the workhorse. You can access almost all areas of the shoulder by it, and this is what I was talking about in the third figure. You need to have a good external rotation and an extension to dislocate the shoulder and then access the humerus. So you take the humeral cuts and you seat the humeral component first, then you have a protector, you place the protector, and then you go and work on your glenoid side, then you put the insert, and then finally reduce the joint. So this is the patient day 1 post-op, and she is able to feed herself day 1 absolutely pain-free. And reverse shoulder arthroplasty, the beauty is that it's quite a stable implant if it is put in a correct position. So you need to look at the surgical planning as well, but it's pretty stable, so you do not need to worry about dislocation and things. So you can allow the patient to feed themselves, to remove the sling while they are awake and do the shoulder movement. And this is the patient who is ready for discharge on day 2. And this is the patient post 1 year. So this is her function. She is pretty happy with full abduction. I doubt you can get this with any other implant rather than a reverse shoulder arthroplasty. And so these are some other cases, just one more minute, where I have done it for, well, this was done in UK, not here. But you can see this is the inlay implant, and this is another case. This is not cuff tear arthropathy, but osteoarthritis cases. Some long-term results. So what are the survivorship? This is one of the very good paper, 10-year survival rate matching that of a knee replacement. We do not have very long-term results of 20 years, but then they do have certain complications, and especially the complication rates are more in patients who are younger, especially younger males. So you'll have to be slightly careful when you're doing reverse shoulder arthroplasty in those patients. This is the NJR data, which is almost 94% survival rate at 10 years. So it works really well in cuff tear arthropathy. The problems are mainly when you do it for trauma, which Dr. Arvind will talk about in a minute. Thank you very much.
Thank you, Dr. Abhishek Das, for nice presentation. After reverse shoulder arthroplasty in rotator cuff injuries, we will have reverse shoulder arthroplasty in trauma cases. I invite you, Dr. Arvind.